Thank you to the organisers for asking me to, well, both bringing me over to New Zealand and asking me to speak today. Both were very generous. I'm going to talk a little bit about the UK's experiences with minimum unit pricing, and particularly our team's work, looking at the effectiveness of a policy and who is affected by it. I'll also talk a little bit about what we don't know about minimum pricing yet and what we hope to learn now that Scotland has introduced a policy and is evaluating it. And I'll also just say a little bit about how evidence has been used in the policy debate in the UK, because I think there's quite a lot we can learn from that for public health more generally. Now, before I get started, I'm going to talk a lot today about units and about drinker groups, so I'm going to define those before I go any further. In the UK, a unit is 8 grams or 10 millilitres of pure ethanol. That's slightly smaller than the Australian or New Zealand standard drink, which is 10 grams. So a pint of beer is around 2 UK units, a bottle of wine is around 9 or 10 UK units, and a measure of spirits, a 25 millilitre measure, is 1 unit. The drinker groups I'm going to use are defined by the number of units people drink per week, and I've also included on the slide just the conversion into standard drinks, so those of you who are more familiar with those know what I'm talking about. So we have moderate drinkers, who are both men and women drinking up to the UK's Chief Medical Officer's low-risk drinking guidelines, which are 14 units a week. We have high-risk drinkers, which are men drinking over 50 units a week and women drinking more than 35 units a week. And then we have the increasing risk drinkers, who are those who lie in between. To give you a feel for what those groups mean, around 16% of the English population don't drink at all, so they're abstainers. 59% are moderate drinkers, 21% are increasing risk drinkers, and then just 4% are high-risk drinkers. But that 4% of the population accounts for 30% of the alcohol that's drunk in England. And if we put the high-risk and increasing risk drinkers together, they account for a quarter of the population, but 3/4 of all the alcohol that is drunk. So a relatively small group of the population are responsible for a huge proportion of the drinking that goes on in the UK. Okay, so if we turn now to look at alcohol pricing policies and why they matter, why do we care about them? The first reason is that the highest risk drinkers buy the cheapest alcohol, which suggests that raising the price of alcohol might have some beneficial effects. This graph shows the average number of units purchased per week for less than 50 pence across our free drinker groups and also across income quintiles of household income as well. If we start with the moderate drinkers on the right, the very small green bars, we can see that moderate drinkers, irrespective of their income, buy very little of this cheap alcohol, just 1 to 2 units per week on average. Contrast that with the red bars, the high-risk drinkers. They buy huge amounts of cheap alcohol, but it varies by income. So the high-risk, low-income drinkers buy on average 44 units of alcohol a week for less than 50 pence, whereas the high-risk, high-income drinkers, they still buy cheap alcohol, but a bit less, 19 units a week on average. And this isn't simply because the highest-risk drinkers are buying more alcohol, so they're buying more cheap alcohol. Cheap alcohol also makes up a greater proportion of their purchases as well. So the purple dots here show the proportion of each group's total units that were purchased for less than 50 pence. And again, we can see a clear gradient, with cheap units being more likely to be purchased by the high-risk drinkers, and particularly by the high-risk drinkers on low incomes. It accounts for around half of all of their units. So what are the cheap units that high-risk drinkers are buying? Well, there are 3 main ways to get cheap alcohol in the UK, and all of them involve shopping at supermarkets, where prices are much, much lower than in pubs or restaurants. The first option is you can buy big multi-packs of beer or cider. And the example here is a fairly standard special offer, where a supermarket was selling 30 cans of Stella Artois at just 32 pence per unit. That's 63 units, so enough to go way over the high-risk drinking limit, for just £21. Second option is you can buy cheap or own brand spirits. Example here is Nikita Imperial Vodka. You can buy a standard bottle of that, 700 millilitres, for 38 pence per unit. So that's £10 for 26.5 units. But the very cheapest alcohol in the UK is cider. Cider is taxed at very low levels, The strong ciders, sometimes called white ciders, tend to be sold in these very big plastic bottles. And the daddy of all of these is Frosty Jack's. And you can buy 3 litres of Frosty Jack's cider for £3.69. That's 22.5 units, enough to exceed the drinking guidelines and with plenty to spare for just 16 pence per unit. Now, the government introduced a new tax on higher strength ciders, which would cover this last week. But that will only push up the price to around £4 for this 3 litre bottle. So just 18 pence per unit. Now, these are the cheapest examples, but just under half of all the alcohol sold in the off-trade, so in shops and supermarkets in England and Wales, just under half, is sold for less than 50 pence per unit, the equivalent of about £1 for a pint of beer. That includes a quarter of all wine, half of all spirits, including 2/3 of vodka and around 60% of whiskey, and more than half of all beer. As I said, cider is by far the cheapest product because it's taxed at a much lower rate than everything else. 30% of all cider sold in the off-trade is sold for less than 30 pence per unit, and around 60% is sold for less than 50 pence per unit. And for those of you who think, well, okay, but Britain's a nation of pub drinkers. We're not a nation of pub drinkers anymore. Almost 3/4 of our alcohol is bought in the off-trade. So what you're seeing here is a huge proportion of the UK alcohol market being sold at very low prices. So if the highest risk drinkers buy cheap alcohol, and this accounts for a large proportion of their purchases, and I don't have time to show you the affordability trend today, but it's going up. Alcohol is becoming more affordable. Would raising the price make a difference? The evidence suggests that it would reduce consumption. So a meta-analysis of over 100 studies found that increasing the price of alcohol was associated with falls in total alcohol consumption, in consumption of each of the different beverage types, so beer, wine, spirits, falls in youth drinking, and also falls in binge drinking as well. And those results have been replicated across a large number of systematic reviews and meta-analyses. And the typical finding is that across different times and places, on average, a 10% increase in prices leads to around a 4.5% fall in consumption. Now, of course, it's not alcohol consumption per se that we want to reduce. It's alcohol-related harm that we're really interested in. And a further meta-analysis of 50 studies concluded that doubling the relatively low US alcohol taxes would lead to a 35% reduction in alcohol-related mortality, an 11% reduction in traffic crash deaths, and smaller reductions in sexually transmitted diseases, violence, and crime. So all of this is why the WHO recommends increasing the price of alcohol as one of its best buy policies for reducing alcohol-related harm. So if we turn to minimum pricing now, minimum prices or floor prices, as their name suggests, sets a threshold below which alcohol can't be sold to consumers. Now, minimum unit pricing is a specific kind of floor pricing where the minimum price is directly proportionate to the amount of alcohol in the drink. So this is kind of different to the policies they have in Canada, where they do have minimum prices, but those minimum prices vary, and they're not directly proportionate to the amount of alcohol in the drink. So you could have one minimum price for beer and a totally different one for spirits. And if the spirits get stronger, the minimum price just stays the same. Minimum unit pricing, it would go up in line, in direct proportion to the amount of alcohol in the drink. So no country in the world has actually introduced a minimum unit price until this year. But things are changing now. There's quite a lot going on, and we'll look at that now. On the 1st of May this year, Scotland became the first country in the world to introduce minimum unit pricing, and it set the level at 50 pence per unit. And importantly, the Scottish Parliament now must vote in 2024 on whether it's going to continue with a policy after they've had some evaluation work done. And I'll talk a bit about that later. But this sunset clause that's built into the legislation is quite an important thing. Beyond Scotland, Wales also passed legislation to introduce minimum pricing. It passed that this summer, and we're expecting the policy to be introduced sometime next year. They're currently consulting on what level they're going to introduce it at. Things are a little bit more messy in England, where the government's performed several U-turns on the policy. Technically, it's still under review, but it's been under review since 2014, and we're not expecting any movement in the short term. Northern Ireland is even messier. The Northern Irish power-sharing government does actually support introducing minimum pricing. Unfortunately, the government collapsed. The power-sharing arrangement collapsed 18 months ago, and it's now the country that's gone the longest period without a government, surpassing Belgium. And there's no signs of the government being resurrected anytime soon because Brexit and everything's a mess. Don't come to the UK at the moment. Beyond the UK, though, there's other things going on as well. So you probably know the Northern Territory in Australia introduced its own minimum price in October this year, of $1.30 per standard drink. And the Western Australian government is also looking carefully at the policy. There's been some indications they will introduce it. There are supportive elements in the government. Ireland, a few weeks ago, passed legislation to introduce a minimum unit price of €1 per unit, and we're expecting that to be implemented next year. And then at different points over the last few years, there have been significant policy debates in Canada, in Australia, in New Zealand, and also in various other European countries. So there's a lot going on with minimum pricing at the moment. If minimum pricing, though, hasn't been tried anywhere in the world before a few months ago, what do we know about its effectiveness beyond the general evidence on alcohol pricing, which I've showed you? That's where our work comes in. So we use the Sheffield Alcohol Policy Model to appraise or to estimate the impact of policies which are yet to be introduced. And we provide estimates for specific times and places, so for instance, England in 2018. And our estimates of policy impact have been particularly important because they cover a very wide range of outcomes, including alcohol consumption, the impacts on alcohol spending, on revenue to retailers and government. We look at the impacts on various alcohol-related harms, both to health and social harms as well. And we also look at the cost of those harms in terms of quality-adjusted life years for individuals and also the direct cost to public services, to the government. And also important, we provide estimates for different groups in the population. And that's been really important for the political process, as you'll see as we go through. We look at groups particularly defined by age, by sex, by income or socioeconomic status, and also by the drinker groups, which I showed you earlier. Now, difficult question, how does the model work? SAPM, we call it. It's pretty complicated. This is how we explained it in the journal Health Economics. This is how Channel 4 television explained it. Those of you who will know our team will recognise Colin Angus stood next to his computer there. Neither of these is particularly helpful, so I'll try and give you a bit of a brief explanation. The model works in sequential modules. So first, we estimate the impact of a policy on alcohol prices. And we do that using market research data, alcohol spending surveys, and analyses of the effect of previous policies on prices. We then estimate the impact of price changes on alcohol consumption. And that's an econometric analysis looking at individual level spending and consumption data. We then estimate the impact of consumption on rates of alcohol, or rather the consumption changes on rates of alcohol-related harm. And we do that using an epidemiological analysis, drawing all those epidemiological studies and meta-analyses summarising the risks of drinking, and also various bits of administrative data as well. And we're looking at over 40 different health conditions separately. Finally, we use a health economic analysis, fairly standard approaches here, to estimate the impact of changes in harm on the costs associated with those harm. So again, don't worry if you don't follow all that. It's not necessary to understand the results. And I'm going to move on to those results now. I'm going to present detail behind 4 key findings. The first of which, not surprisingly, given I'm here, is that minimum pricing is effective as a policy. So this is a summary of the estimated effects of a 50p minimum price introduced in England. So overall, we estimate it would reduce consumption by around 3.5%, and that would lead to around 900 fewer deaths per year when the policy is having full effect in year 20, and around 22,000 fewer hospital admissions per year due to alcohol. In the first year, we'd expect to see around 49,000 fewer crimes and around 160,000 fewer days absent from work. In terms of the total cost reductions, you can see the breakdown there across various things. But the headline finding is in terms of reduced cost to individuals, in terms of quality of life losses, and reduced cost to public services, totaled over 20 years, is a reduction in the cost of alcohol to society of just under £15 billion. You can see at the bottom of the slide the revenue changes as well, and these are quite important. So off-trade retailers, because alcohol isn't a tax and the money simply is kept by businesses, off-trade retailers would see a large revenue increase of around £350 million. And that's one of the biggest criticisms of the policy from a public health perspective. The on-trade would also see some small benefits as a kind of knock-on of people changing their drinking patterns. Revenue to the exchequer, though, to the government from alcohol taxes will be largely unaffected, and that's because the fall in alcohol duty revenues due to lower volumes of alcohol sales will be largely offset by an increase in sales tax revenue because the remaining alcohol is being sold at higher prices. So those two things largely cancel each other out. Okay. So that's the overall picture, but who's actually affected by minimum pricing is perhaps as important as whether it works at all. And the second key finding is that minimum pricing is a very well-targeted policy. So I want to briefly remind you of this graph, which shows who's actually buying the cheap alcohol that's affected directly by the policy. And again, it's the heavy drinkers, and particularly those heavy drinkers on lower incomes. So as a result, when we look at this slide of the estimated annual reductions in consumption across the different groups, we can see that it's, again, those groups that I've talked about who are particularly affected. But if we look at the moderate drinkers again, irrespective of their income, moderate drinkers are their consumption is largely unaffected by the policy because they simply aren't buying the cheap alcohol that it targets. So even moderate drinkers on low incomes are only reducing their consumption by around 6 units per year. That's about 3 pints of beer. Contrast that with the high-risk drinkers, and the high-risk drinkers on low incomes are reducing their consumption by an estimated 750 units per year. It's around 75 bottles of wine. Even the high-risk drinkers on high incomes are still cutting their consumption by around 50 units, so about 5 bottles of wine. But you're still seeing, right across the high-risk drinker group, quite significant reductions in consumption. And because of these targeted reductions in consumption, and also because of the increased harm per unit of alcohol consumed that lower income and lower socioeconomic groups face, so for those of you who don't know, there's fairly good evidence that lower socioeconomic groups face a greater risk per unit of alcohol consumed than higher socioeconomic groups. Because of that, and because of the targeting of a policy, the health benefits are also hugely concentrated in lower income, higher risk drinkers. I've switched from income groups to deprivation quintiles, so this is an area-based measure here, but the same basic picture is the same. The reductions in alcohol attributable mortality rate are very concentrated in the highest risk drinkers. And we'd see the same thing if I showed you the results for hospital admissions. Now, I should mention here that everything I'm showing you is the base case estimates from our model. Over the years, the last 10 years we've been working on this, we've done a huge number of sensitivity analyses and adapted the model to different countries and updated it with new data sets. We've also we've tested different modelling assumptions, and we've tried different analytical methods. And of course, all these different versions produce slightly different results. But the actual conclusions that the policy is effective, that it's well targeted, those seem to be really robust to all these different versions of a model we can try. So these appear to be really robust conclusions. If we turn to our third key finding now, although minimum pricing delivers a windfall to retailers, and that's kind of bad from a public health perspective, it does have advantages compared to alcohol taxes, where of course the revenue would come to government, and we can live in a world where it might do positive things with that money and increase spending on treatment and such like. The UK government gets £20 billion from alcohol treatment every year, alcohol taxes every year. It spends about £100 million on treatment. So, yeah, that's aside. Anyway, so we compared the effects of a 50p minimum unit price to 3 different taxation policies to see how they affected different groups in the population. And to make it a fair comparison, we picked 3 policies that would have the same effect on total consumption as a 50p minimum price, which in this version of the model, a slightly earlier version, was 4.3% reduction. So the three other policies were a 13.5% increase in current alcohol taxes as they stand in the UK, a 4% additional sales tax, or VAT as it's called in the UK, and then replacing the slightly erratic system of UK alcohol taxes with a volumetric tax where, irrespective of a product, the tax was 22 pence per unit of alcohol. And as I say, all of those policies have the same effect on total consumption, but as we can see here, they affect the groups in the population quite differently. So we've got our moderate, increasing and high-risk drinkers again, and you can see the current tax increase and the increase in VAT, the effect is reasonably flat, at least in relative terms, across the drinkers. So this is percentage reductions in consumption. But if you look at the volumetric tax and minimum pricing, the impact on moderate drinkers is much smaller, or a little bit smaller, and the impact on high-risk drinkers is much, much bigger. So those two policies, and particularly minimum pricing, are much better targeted than simply increasing current taxes or VAT on alcohol. Because these policies also affect socioeconomic groups differently, and this is all driven by which types of alcohol people buy and how much they pay for it. There's big social differences in what people buy and how much they pay, and that's what's driving these differences across our subgroups. Because these policies also affect socioeconomic groups differently, they also have different impacts on health inequalities, which is, of course, another important outcome. Now, this graph is slightly different, and what we're interested in here is the gap between the red triangle and the black diamond. The red triangle is the alcohol-related mortality rate in routine and manual worker households, or rather drinkers in routine and manual worker households. The black diamond is the same mortality rate, but in professional and managerial households. And if we look on the left, we can see the baseline, there's a big gap in the mortality rates between those households. And of course, we know that there are big alcohol-related health inequalities. All four of the policies reduce that gap to some degree, but the biggest reductions are seen for minimum pricing and for the volumetric tax. So again, not only are these policies better targeted in terms of who they affect in terms of their consumption, minimum pricing is also a better targeted policy if you're interested in reducing health inequalities. Okay. The last point I want to make isn't actually from our own research, it's from the evaluations of minimum price increases in Canada that have been done by Tim Stockwell's team. They've evaluated the effects of changes in the real terms value of minimum prices, not minimum unit prices, remember, slightly less stringent forms of a policy. They've looked at this in different Canadian provinces, and they've found beneficial impacts across a wide range of outcomes. So they estimate that a 10% increase in minimum prices would be associated with a 3.5% reduction in consumption in British Columbia and an 8.5% reduction in consumption in Saskatchewan province. In British Columbia, they also found that increases in minimum prices are associated with falls in deaths that are wholly caused by alcohol and also falls in hospital admissions. And again, crucially, these falls in hospital admissions were greater in the geographic areas which had lower incomes. So again, evidence here that minimum pricing is reducing health inequalities. The health benefits are bigger in lower income areas. Tim Stockwell's team also found beneficial effects on crime in British Columbia, but those effects were less consistent in Saskatchewan province. But overall, it seems to be the evaluation evidence is suggesting minimum pricing is an effective policy, and we'd expect minimum unit pricing to be even more effective because it's more targeted on actual alcohol strength, so it's a more rational approach to it. Now, I've shown you a lot already about what we do know about the effects of minimum pricing, but there's also something to be said about what we don't know. What do we actually lack evidence on? So, firstly, regulatory interventions of this scale, big moves into the market by government, are actually fairly uncommon, not just in public health or for alcohol, but just in general. So we don't actually know a lot about how producers and retailers are going to react to this policy. So for example, our model assumes that products sold below the minimum price threshold will all simply just move up to the threshold. Now that might not be the case. We might see those price increases, but we might also see products being withdrawn from the market. Certainly we'd expect those very cheap ciders. No one is going to buy those when they cost £12. When you do qualitative work with the people who are drinking them, they look at you slightly funny if you ask why you're drinking it. The answer is clearly because it's cheap and it's strong. They're certainly not drinking it for the taste. Another possibility is that the industry may reformulate some products, so reduce its alcohol content so they can continue to sell it at the same price. And we're seeing some small reformulations going on in Scotland already. Some of these effects, of course, will be short-term. We might see others emerging over the long term. And for products sold above the minimum price thresholds, again, we're not quite sure what will happen to those. Our model assumes that they will all just simply stay at the price point they are. They're not directly affected. But it may be the case that products that consider themselves premium brands decide to increase their prices so they're not at the bottom end of the market if they're close to the minimum price threshold. Alternatively, some products may decide, actually, we don't want to increase the price. We're just going to rebrand our product and we're going to become a more budget brand or a more mainstream brand. Again, we don't know what will happen, and we're waiting to see what will happen in Scotland to find out. Another important question is, what do the off-trade retailers do with all that extra revenue they're getting? And one of the concerns is they might use it to increase marketing on alcohol. Again, it's something important that we need to look at. We also know relatively little about how people who are dependent on alcohol are going to react to this policy. So people with alcohol dependence, and particularly severe alcohol dependence, are not well represented in the surveys which our modelling relies on. So it's not necessarily the case that our estimates actually apply to that group. We would expect them to respond in some way because we know they're buying huge amounts of this cheap alcohol. And we also expect that their dependence may mean that they react differently to price increases to other groups in the population, at least to some extent. But we only have very indicative evidence on this at this point. So, for example, a survey of homeless people with alcohol dependence in Canada asked how respondents coped when alcohol became unaffordable. The most popular responses were to go without alcohol, to make their supplies last longer, to wait for money, or to re-budget, which in practice means spending less money on essentials such as food and heating and housing. Other options included seeking treatment, drinking non-beverage alcohol, or using drugs, or rather, illicit drugs. So a mixture of potential responses with both positive and problematic outcomes, not uncommon. And I think the most we can draw from the evidence at this point, and this is obviously quite weak evidence, is that the response of dependent drinkers to minimum pricing may be quite varied. It may be quite individual, depending on the exact problems that the individual has. And it requires careful attention and monitoring to head off any problematic outcomes. There are also some other important uncertainties, which I'm not going to go into today, around the effects on younger drinkers and also on harms to people other than the drinker, so harms to others. I want to step away, though, for a moment from discussing the effectiveness of minimum pricing to instead consider how that evidence is being used, or how the evidence I've been showing you is being used in the policy debate. And I think that can tell us some useful things about how evidence can be used to inform or to influence public health policy debates. And minimum pricing is actually quite a good case study for this, for three main reasons. Firstly, the policy was very much sold by its proponents on the strength of the evidence. And as such, it might be portrayed as an example, or as a good example of evidence-based policy making. Secondly, the dominant role played by our work, the Sheffield Alcohol Policy Model, in the policy debate, and also at later stages by the Canadian evaluations, means that it's quite easy to identify the evidence that was in play that we're talking about when we're asking how it was used. And all the policy actors engaged with it in some way and have something to say about it. Third point is that researchers have actually studied this question. There are some nice papers looking at how evidence was used in this particular debate and looking at how specific pieces of evidence were used. And I'll talk about that in a second. Now, of course, there's a growing body of research, and we heard a little bit about it earlier, detailing how industry actors engage with public health evidence. This study by Jim McCambridge and colleagues identifies 4 approaches used by the industry to contest the Scottish Government's wider alcohol strategy. Those approaches were misrepresentation of strong evidence, promotion of weak evidence, making unsubstantiated claims about adverse effects of policy, and also promotion of alternative policies without actually having any evidence to support them. Now, of course, this is really important, but I don't want to dwell on it, partly because these tactics are increasingly well documented, but also because we know much less about how non-industry actors actually use policy in the debate. And that's what I want to focus on more. So there are three quite helpful studies of the minimum pricing debate which look at how non-industry actors use evidence, and you can see those here. And they all largely point in the same direction and raise productive questions about the relationship between evidence and advocacy in public health. And I want to highlight 5 key points, which start off as a story of evidence and evidence-based policy, but end up somewhere a little bit different. So firstly, the studies find that evidence did actually inform the policy discussion and make a real difference, but only to a degree. So it informed, highlighting the targeted nature of a policy did make a difference, and also evidence combining the effects of different policy options, such as minimum pricing versus tax, or different levels of minimum pricing, whether to go for 50p or 60p or 70p. Those were important pieces of evidence that did make a real difference to policymakers' decisions. But that impact on the policy was not an accident. It was kind of built in from the start. So the work that we did was developed in collaboration with policymakers, and it was designed to speak to policy questions that were already in discussion within the governments that commissioned the work. It was also designed to deliver evidence on health, social and economic questions which would be relevant to a broad range of stakeholders, rather than just narrowly answering public health questions. And finally, it tried to engage with key aspects of a policy debate, so this comparison between moderate and harmful high-risk drinkers and the impacts on low-income drinkers. This was all built in by design, and the idea was that the research would be sensitive to both the policy and the political context in which it had to operate. That was all built in from the start. Third point is that the academic credibility of the evidence did matter, but it wasn't simply bestowed. And people have this kind of vision sometimes that simply because research is academic research, it should have an impact and it should be treated with respect. That's not necessarily the case. In this case, the credibility of the evidence had to be earned. And these studies that I showed you talked about public trials of strength, where the researchers, me, my colleagues, Tim Stockwell's team, had to go out in public and define and have their evidence examined and defend it. And that process was really important for actually establishing the credibility of the evidence, establishing that you couldn't simply dismiss it easily. And that, again, made a real difference to the fate of a policy. Fourthly, the evidence was used often rhetorically or symbolically rather than simply for its scientific content. So, for example, it was often used to bolster people's pre-existing positions or ideas they already had about the policy, rather than to actually inform those decisions. It was simply supporting a position they already held. Another important point was the presentation of outcomes such as health consequences and the ability to talk about lives saved and crimes prevented placed policy opponents in a difficult position where they were having to say why saving lives was a bad thing. So being able to keep the policy debate focused on these emotive topics rather than talking in terms of the effect on the economic aspects of the alcohol industry was a big advantage. And having those clear numbers saying this is the number of lives saved, this is the number of crimes prevented, again, kept the debate in an emotive area rather than a technical area, and that was advantageous to public health advocates. Finally, many public health actors had to reconcile their commitment to evidence-based policy with the demands of the political arena. So in practice, this meant preferences for retrospective evaluation evidence, which many people had. They regarded it as the gold standard evidence, but they had to set that aside in favour of our modelling because that was what was available. And they had to argue strongly in favour of that model as a kind of gold standard piece of work, despite that not being the position they necessarily held. Interpretations of research were sometimes aligned with political perspectives rather than with what the evidence actually said. Uncertainties were sometimes downplayed or marginalised, and the kind of complicated methods of a model, which I've shown you already, were seen as advantageously opaque, as they conveyed a scientific authority while actually being quite difficult to challenge. And that matters as well and was a kind of useful position to have. Now, all of this matters because it suggests that the success of minimum pricing was not simply a case of evidence-based policy, but rather, as the authors of those papers I mentioned suggest, a case of evidence-informed advocacy. So rather than evidence straightforwardly influencing a policy decision, researchers, policymakers, and advocates interacted over time, each playing their role in a kind of mutually reinforcing process that allowed a challenging policy debate to be won. And I think the broader lesson of this is that, yes, public health research can have an impact on policy, and simply doing a high-quality piece of research is an important part of that, but it's unlikely to be enough on its own. So effective collaboration with different stakeholders in the debate, effective dissemination, defending the work, explaining it well, and effective negotiation of the difficult tensions between scientific evidence and the political debate are all important things that have to be in place as well for public health evidence to make a difference to public health policy. Okay, this brings me to the last section of my presentation. As I mentioned earlier, the Scottish legislation contained a sunset clause, which means that in 2024, the Scottish Parliament will vote on whether to continue with minimum pricing, and unless the Parliament votes in favour, the policy will automatically expire. And to inform that vote, the Scottish Government has commissioned its National Public Health Agency, NHS Health Scotland, to conduct a comprehensive, robust and impartial evaluation. And I'll thank Claire Beeston from Health Scotland here for allowing me to use her slides. She's leading the evaluation. So the evaluation will answer two questions. To what extent has minimum pricing contributed to reducing alcohol-related health and social harms in Scotland? And are some people or businesses affected positively and negatively more than others? And I think the key point here is that this isn't simply an evaluation that's going to say the policy worked or it didn't work and this was the effect it had on alcohol-related harm. It's going to be a much more nuanced and detailed analysis of lots of different aspects and lots of different questions, and some of those may suggest the policy had positive effects and some may suggest it had negative effects. In terms of what's actually in the policy, it's a mixture of work done in-house by Health Scotland, work commissioned by Health Scotland to universities and consultancies, and then linked-in studies funded by other research funding bodies. And at the moment, there are 14 studies funded by Health Scotland, 3 by other research bodies, and then 6 further studies under development. So this is a really comprehensive piece of work. In terms of what the evaluation will cover, it's got 4 main themes: implementation and compliance, the alcohol market, alcohol consumption, and alcohol harm. So if we look at what's in some of those, the implementation and compliance strand looks at how alcohol prices will change, the economic impact on the alcohol industry, how small convenience stores adapt to the policy, and also the price changes associated with very specific products of interest, such as Frosty Jacks. The studies on alcohol harm, by comparison, will look at impacts on those drinking at harmful levels, including those dependent on alcohol, as I talked about earlier. It will look at effects on crime, on hospital admissions, on alcohol-related deaths, and also effects on children and young people, both in terms of their own drinking and also how they're harmed by other people's drinking, most obviously their parents. Okay. And last thing, in terms of when we'll see the results, which I guess is the most important question, the policy was implemented on the 1st of May this year. So in the next 12 months, we'll get some early anecdotal and preliminary data, but that's likely to have very major limitations to it, and I'd be very cautious, including about some of the claims that have already been made about the effects of a policy. The first robust evaluation results are not likely to be available until the middle of next year and then for the 2 years after that. We'll start to get a sense there of any immediate and obvious big effects. The main period, though, is going to be that period 3 to 5 years after the policy is implemented. That's when these main evaluation studies will start reporting and we'll start to get the most robust estimates of what the policy effects have been. Now, obviously, there is some evidence that will emerge after that, but I think that's the period when we're going to start to see the most important findings. And from everything we've seen already about the use of evidence by industry, by researchers, policymakers and public health actors, I think we can expect it not to be a straightforward translation of evidence into the Scottish Parliament's vote and also into the policy decisions made on the basis of those evaluations by other countries. So I'll leave you by just noting I don't think we're anywhere near the end of the journey in the UK on minimum pricing. Thank you.
Thank you very much.